So hello, Infodemic managers. I'm Dr. Christine Czerniak. You can call me Chris. And great to see this exciting session here today as the World Health Organization and partners are advancing social listening for public health to support countries in better preparing for and responding to infodemics so that people can more easily access the health information they need when they need it, especially during a health emergency. And I'm going to share a little bit of context for what has led to the development of EAR social listening, this pilot project, before I jump into a quick look at how it works, because social listening for infodemic management is about a lot more than any one particular tool or technique. And we know there's a need for ongoing research and collaboration in this space to gather insights from as many different data sources as possible, online and offline, to work collaboratively, really with communities in fostering a healthy information ecosystem and sustainable practices towards good health for all. So we know that at the beginning of the COVID-19 pandemic, the WHO Director General raised the alarm about these twin challenges of fighting an infodemic whilst also fighting an epidemic. So a call to global action for making infodemic management a priority for public health. And we know that an information epidemic can be characterized in lots of different ways. And because this is a rapidly evolving discipline, the definition will need to keep being updated. So for today, for simplicity's sake, it's helpful to keep in mind the 4 V's. So we'll touch on information volume, information velocity, information voids, and information veracity. And there are more dimensions of an infodemic that could be analyzed too. So coupled with other challenges to public health programs, such as trust issues, values differences, and variation in health literacy, information literacy, and science literacy, among the other literacies, this high information volume, so the overwhelming amount of content, and its velocity, the speed at which it's shared, it's simply making it too difficult for people to distinguish between helpful and harmful information so they can take appropriate action. Information voids, so these are the gaps in information and understanding. They're a serious risk, especially when we're dealing with a new health emergency or really any new situation where there's limited evidence. So natural disasters, chemical, biological, radiological, and nuclear accidents and deliberate events are included here too. Now, when there are these data deficits, speculation quickly fills those vacuums and might lead to people making more risky decisions. So we know that veracity of information, as Sarani flagged up, our 4th V, this is another infodemic challenge for us. The messages circulating, they can be misrepresentations of science and health expert advice, or even outright falsehoods. And the scientific evidence and corresponding health policies themselves are also changing over time. We know this is how science works. It's a self-correcting method, not a static body of knowledge. And it's good when policies change to keep up with the science. But that process is causing a lot of confusion, especially when changes in information happen quickly. And when that confusion or false or misleading messages get amplified by algorithms online and spread offline, it can lead to serious harms. And we've seen the tragic reports during the pandemic about people being poisoned by drinking methanol or improperly using cleaning products, or even getting hospitalized after dosing themselves with ivermectin intended for animals. And maybe you've heard of people seeking out herbal concoctions based on rumors instead of implementing basic public health and social measures, such as wearing masks, quarantining when sick, or basics of getting a COVID-19 or flu vaccine. So we know that we need to better manage the infodemic to save lives during health emergencies, to build and maintain trust in science, in health authorities, in healthcare workers and health measures, so that we can build our resilience to infodemics and support health literacy with universal access to credible information as a basic human right. And we can't entirely prevent information epidemics, and freedom of expression is a human right to be protected, but we can better prepare for infodemics and better manage them for public health. And social listening can help us do that, because looking for and listening to and analyzing the questions, comments, and concerns people are sharing publicly online, as well as offline, is helping public health teams and communities better understand the issues and emerging sources of confusion so they can be addressed sooner, hopefully before harmful narratives fill information voids and before people get hurt. And it's important that we strengthen capacity for social listening as a routine activity, as part of health programs, as well as preparing for surge capacity during an infodemic. And you might have heard of some of this being framed as surveillance, and I'm going to challenge us here for a minute to think differently about this. This is really about supporting a more collaborative approach to public health. Just like in relationships when people need to listen to each other to talk about how to solve their problems. Organizations, communities, healthcare workers, and decision makers need to be able to hear from as many people as possible in civil society to better understand their concerns so everyone can work together to address emerging health threats. But when actively listening to so many voices and views, how can we do this during an infodemic without getting overwhelmed by millions or even billions of messages of varying relevance to get useful insights to decision makers faster? We know that commercial social listening services, they're not really designed for public health teams because they're more focused on the brand management side of things. And media monitoring, well, frankly, it leaves a lot to be desired for us because we also want to be able to detect signals of challenges before they go viral and are being covered widely in mainstream media, because it's important to hear concerns people are publicly sharing as soon as possible to enable a more rapid response. So in March of 2020, the WHO Information Network for Epidemics, known as EPI-WIN, worked with collaborators to develop this new method for making social listening more efficient for public health teams by using a taxonomy of relevant categories to filter millions of publicly shared messages about COVID-19 to help us separate the signals from the noise. And you can follow the link to read the journal article for more background, and I'll pop links into the chat after the talk that you can click onto. But briefly, what do I mean by social listening taxonomy? Well, we can think of it kind of like a tree. The trunk is our general topic of interest, in this case, COVID-19, though it could be other topics like pandemic influenza or Ebola or Zika virus, addiction, nutrition, food safety, really anything health related. And the trunk is our broadest filter, gathering all the publicly shared content on that topic from various sources. And then the branches and twigs, these represent the finer follow-on filters for more targeted analysis. So for example, proactive measures like vaccines to lessen the severity of disease versus treatment options when someone is already sick. And what we do is we construct complex Boolean strings, which are combinations of search terms, to be able to pull out the relevant messages for each branch and twig to see which issues are receiving more attention in a given week and where there's a concentration of questions indicating a critical information void. So it sounds like a good idea, right? But does it work? That's the question. Well, yes, I'm happy to report that it does work. We implemented the taxonomy with a collaborator using different social listening tools. And by July of this year, the social listening team, they'd already processed 1.4 billion mentions of COVID-19 directly related to the COVID-19 public health taxonomy, including 70 million posts likely to be a question. The taxonomy, it's covering digital content globally in 3 languages for 35 topics using 10 different open data sources and fora. So think, web comments, YouTube, social media like Twitter, Facebook, Instagram, and Google Trends data. And the insights, they've been really helpful for feeding into our risk assessment process and informing infodemic preparedness and response plans during the pandemic. However, important to note that each report still takes about a week to generate, with a lot of manual effort by the human analysts to finesse the category sorting and pulling out of those insights. And so a side note here that this is why you infodemic managers and your teams are so important, because there's a need to keep growing the local, national, regional, and global social listening analyst workforce. So the human analysts are key. So in parallel, what we've done is the EPI-WIN team looked for a way to try and come up with a more efficient process to automate part of this process, to be able to detect changing narrative trends more quickly, because time is of the essence during a health emergency. So based on this methodology, we worked with another collaborator to automate the social listening taxonomy. So this is using big data from open sources and AI to help countries see how concerns and critical information gaps are changing on a daily basis to empower decision makers to better serve the changing needs of communities during an infodemic. And this open access tool called EARS, it was launched in December of last year as a pilot. It's currently running in 9 languages for 30 countries, covering more than 40 COVID-19 categories. And I invite everyone to take a moment. You can actually go to the open access public dashboard now and have a look. The web address is www.who-ears.com. And you can see what topics are currently trending based on more than 50 million publicly shared questions and concerns that have been a part of the COVID-19 public health conversation, filtered through the taxonomy so far. And if you're wondering, EARS stands for Early AI Supported Response with Social Listening, quite a mouthful, which is why we use the acronym. So if we want to see some of the features for a quick look, looking at the open access platform, we can see here the trends for the past week or month from publicly shared online narratives via the web, Twitter, health-focused Facebook public pages, and it's possible to add more open access data sources too. So as an example, we can see if most of the conversation about COVID-19 right now is about the vaccines or about transmission concerns or travel measures or other topics. And beyond what's already trending based on conversation volume, we can also toggle to see what's on the rise based on velocity so we can get a head start addressing those questions or concerns. And it's helpful looking at the global picture, but it's also really handy when you wake up in the morning, you can click in to check what's trending in your region or even in your country. And looking at these longitudinal trends can help us to pinpoint dates of interest for a deeper dive into narrative analysis using your suite of social listening tools. And it really supports as well forecasting to be able to help anticipate changing needs so that you can work ahead. So for example, if we see a spike in discussion about COVID-19 vaccines, you do your targeted search and you find there's an unfounded rumor leading to a spike in concerns, then we would be able to activate a rapid response to amplify credible health information, maybe pre-bunk and feed this insight into ongoing work to help inoculate more people against these types of rumors before they're exposed. And the idea here is that rather than waiting until we're already at the top of a peak, we can see these changes in slope and actually take action as soon as possible when something's just rising. So this is why it's also really helpful to be able to disaggregate the trends by questions and by concerns or complaints, because the type of response needed may be very different. And because we want to detect those questions, specifically those information voids, as early as possible, to have the opportunity to engage more proactively with credible health information and inoculation activities, rather than feeling like our public health teams are always on the back foot, only reacting to misinformation that has already gone viral. I also want to flag up quickly for us here that the heat map on the platform can show you at a quick glance where there are outliers in the global conversation. So where there's relatively more or less discussion of a particular topic. And you can see if there's a detectable male or female skew for the posts on a given topic to help you determine if a more gender sensitive approach for certain issues may be useful. You can also go into a country report to look at the trending keywords and hashtags as a jumping off point to then go and do a more targeted search for that given date or time frame and topic using your social listening toolkit. And in our social listening work, we use a lot of different tools because any one data set will always have its own inherent limitations, which is why triangulation is key. And for WHO licensed analysts, there's an authorized backend with additional analytics where teams can get daily or weekly alerts to help quickly focus their narrative analysis. Again, we're trying to find those ways to make shortcuts to make it as efficient as possible for teams who are already stretched so thin. And then we can see if conversations are trending more positively or negatively as a quick indication of where more attention may be needed. And we can also do transversal analyses using Boolean searches of the posts themselves, which are available in the backend, which have been anonymized for ethical reasons. And the EARS pilot, it's already in use to help translate infodemic insights into action. And as a case study example, these digital insights, they're already being included in the weekly and monthly Africa Infodemic Response Alliance trends reports. So this is a WHO-initiated coalition of 14 organizations working together hand in hand to identify information voids and address misinformation and boost resilience to the infodemic. And I encourage you to take a minute to go check out their Viral Facts Africa campaigns on social media and help to amplify. So digital information, we know that it provides some useful rapid insights, but like any data set, it's also going to have its limitations. For example, listening to communities with lower internet access and working to overcome algorithmic biases. So I want to be clear that it's not meant to replace offline data. It's a necessary complement to it. And gathering offline information, it's still extremely valuable because it can help analysts to evaluate their hypotheses and assumptions using different data sources and really give teams deeper insights into the underlying drivers of emerging trends. For example, if some people are feeling concerned about a new health policy, deeper focus group conversations and key informant interviews, they may help to shed more light on the signals that we're picking up from the publicly shared online comments. And it's worth mentioning that the EARS platform also enables integration of other offline data in the back end for triangulation purposes. For example, knowledge, attitudes, practices surveys, rapid ethnographic assessments, SMS surveys, and the like. So a point that we can't emphasize enough to consider using both online and offline data when looking for infodemic insights and when designing your infodemic preparedness and response strategies and activities. Because triangulating across different data sets, this is a key part of the social listening workflow for infodemic management. And this requires trained analysts who are conversant with integrated analysis of different data sets. And no matter how sophisticated social listening tools and technique gets, we have machine learning and AI, and it's really exciting, but there's always a need for social listening analysts to make sense of it all and help turn insights into recommendations for action. And this is one of the reasons why WHO is continuing to invest in training experts from diverse disciplines in infodemic management strategy development and techniques, including social listening. And we're empowering a global community of practice of more than 500 infodemic managers from 120 countries and counting. And we're also working with partners on new resources to help you in your journey towards more efficient and sustainable social listening and to become an even more effective infodemic manager. So I invite everyone to keep an eye on the WHO Infodemic Health Topic page. And if you haven't already, please do sign up for the Infodemic Management Newsflash. And as a final point here, wrapping up, there was a great question that came up, Liz, that you raised earlier about the challenge of how we can better hear from more vulnerable and marginalized communities, including displaced and migrant communities, because we do need to make an extra effort to reach these people so their voices and views are heard and they're part of health programming, because public health is a collaborative endeavor. So if people can be reached by mobile phone for tech surveys and messages and interviews, that's great, or share their thoughts online, that's great, but we know that may not always be an option. And as an example, early in the COVID-19 response, when I was supporting a One UN collaboration in Asia, we needed to think really carefully about how to listen to and support different communities, such as the Rohingya in Bangladesh. So in addition to gathering questions and concerns that were being raised through the hotlines, we strengthened partnerships between the ministry, local NGOs, other UN organizations like FAO, the World Food Programme, UNICEF, and UN Women, and these boots on the ground experts from all these different organizations, as well as a trained cadre of local community support teams. They were delivering different services based on their mandate. So masks, wash stations, food, medicine, financial support, addressing gender-based violence and more. And we trained them to ask key questions when they were providing these services and information to enable two-way information exchange. And this included hard copies of information with phone numbers to call for more information, so not only relying on websites, and these were plastered everywhere. And then considering those literacy challenges, there were the radio ads and then local miking transects where vehicles would drive around sharing resource information by megaphone, and then anyone approaching could then share their questions, and this would also get fed back. And the National Network of Mosques, they were also prepared with resources and included in that really important information gathering process. So we would regularly interview these different workers and volunteers, as well as the hotline workers, in addition to collecting data through surveys or online to form a better picture of the changing situation and needs of people whose voices may not have been heard online. And of course, there was the formal IMST structure, with coordination with the ministry and this community support team initiative connected through the UN resident coordinator. It made it a priority to grow organically through the networks of local NGOs and community-based organizations. So in closing here, I'm challenging all of us, myself included, to keep thinking about how we can strengthen coordination and preparedness so that all of these important services that are being offered, they're also functioning as a mechanism for community feedback and accountability to affected populations. So when FAO and WFP were out there delivering food baskets, they were also collecting feedback. And when WHO and UNICEF were creating wash stations, they were gathering feedback. And when UN Women, created a program for Rohingya women to get paid a fair wage making masks, they were also collecting feedback. And this was all collectively fed into the community support team working group as part of Pillar 2 for discussion on where to adjust strategy, the response, the resource allocation in coordination with the other pillars. So this was much bigger than only risk communication and community engagement because health ops and other teams were integrated. So the greatest lesson from that experience is to use what's there and build relationships now with all of those local networks and create the coordination mechanism so that in an emergency, the information can easily flow from as many sources as possible, including more remote and vulnerable groups. And I expect we might be tight on time, so I think Tina may be able to answer questions about EARS because EARS is actually her creation. So thank you. Back over to you.